She's hope connected. Oh, hi, Karen. How are you?
Hello, hello, hi.
Are
How
you
are
are you
you?
are you in South Africa now?
Yes, yes. Unfortunately, I can't be with you in Berlin. I was in Berlin 2 weeks ago, but I just can't fly down 9,000 kilometers again to be part of the great meeting. But so that's why I'm here now. Yes.
Thank you to be with us today. Professor Karen Sliwa is going to talk about risk stratification in women at risk for peripartum heart failure. Please, Karen.
Thank you. So, just imagine you're all in Berlin, I know, and you are a doctor at the Charité, which is not far from you. I'm actually from Berlin, I know. And you're seeing a pregnant woman who is 20 weeks pregnant, and she's from South Africa, and she is visiting her sister in Berlin, and she presents with shortness of breath. So she's still allowed to fly because she's still not only 20 weeks pregnant. So where do you start? So you have never seen the patient. So what can be your approach? So the patient can have a known pre-existing heart disease, such as congenital heart disease, Marfan's cardiomyopathy, rheumatic heart disease, which we have a lot in South Africa, valve prosthesis when she was operated. She can be presenting with a newly diagnosed heart disease unmasked by the pregnancy. So for instance, she could have familial cardiomyopathy, which was not diagnosed, previously undiagnosed rheumatic heart disease, undiagnosed congenital heart disease. But she could also technically, but she's not far ahead with her pregnancy, have a newly developed heart disease such as peripartum cardiomyopathy, which presents more like a last week of pregnancy or postpartum. She can have acute coronary syndrome or pre-existing ischemic heart disease, which we see more and more common, gestational hypertension, preeclampsia, or severe hypertension. Does it matter where the patient comes from? Yes, it does. So in higher income countries, you have now an increased maternal age for the first pregnancy, and that is linked to pre-existing hypertension, obesity, as I mentioned already, pre-existing coronary heart disease. If you come from lower income countries, which for instance is South Africa, you can have, as I mentioned, rheumatic heart disease. When you're from South America, there are clearly women who have Chagas cardiomyopathy. You have also commonly unoperated congenital heart disease, which only presents with symptoms and signs in pregnancy. And in all other regions, you need to be aware that there's an increase in the diagnosis of cancer-induced cardiomyopathy. So the pregnancy with this increased load is unmasking pre-existing heart disease. So if someone had a cancer and was treated childhood, let's say for leukemia, they can have left ventricular dysfunction and present then in pregnancy with heart failure. They can have rarer condition as left ventricular non-compaction cardiomyopathy and others. So I want to show you how to risk stratify those women and why is it important. So there are several classifications, but there is a modified World Health Organization classification, which is most commonly used and also has a best value of risk prediction. So I'm just showing you this one. So you can see here, so if you have a WHO1 classification, this is, for instance, I didn't put it on a slide. If you have operated atrial septal defects, you're fine, small defect in your heart is closed, you're not on symptoms. This is, for instance, someone who has WHO group 1. WHO group 2, so you can see the maternal cardiac event rate, which includes hospitalization, severe arrhythmias, possibly death, is 5 to 10%. So in that group, you have unoperated ASD, ventricular septum defect, repaired congenital heart disease like a repaired tetralogy of Fallot, most arrhythmias, when you have mild left ventricular impairment, a genetic condition like hypertrophic cardiomyopathy, native, that means non-operated or tissue valvular heart disease, and Marfan syndrome without dilatation of your aorta, which is less than 45 millimeter, and repaired another congenital heart disease coarctation. So WHA group 3, you can see the maternal cardiac event rate is already around 20 to 27%. So it's relatively common, 1/3 of the patient. Everyone with a mechanical valve. Then you have this genetic disorder like systemic right ventricular fontan circulation, cyanotic heart disease, other complex congenital heart disease, or when you have Marfan with a more dilated aorta. 4 is important to remember because the maternal cardiac event rate is 40 to 100%. This is where pregnancy is actually contraindicated. It's any pulmonary artery hypertension, severe left ventricular dysfunction, so ejection fraction less than 30%, anyone with a previous peripartum cardiomyopathy, residual left ventricular function, severe rheumatic heart disease, so that's severe mitral stenosis, severe symptomatic aortic stenosis, and other conditions. So the most important thing is the preconception evaluation. So as I've told you, our patient, the one who arrives at the Charité, didn't have that. So, but ideally, in most scenarios, the patient do know that they have a heart problem. And it's important that even when young couples, young women visit their cardiologists, their physicians, that the aspect of pregnancy is discussed. And why is it so important? First, is you need to risk stratify. I told you about this classification. So you need to, the patient, I mean, it's not a patient at that stage. The woman and the partner need to understand what it means to have a pregnancy. So the risk stratification, you need to do an ECG, an echocardiogram, an exercise test. And then you need to really spend time with careful counseling, which includes the maternal risk for complications that I showed you already. And then, but also choices of treatment, which do have effect on the risk of miscarriage, the risk for early delivery, the risk for small for gestation. So there are long-term implications for the babies of women born with congenital heart disease. And it's also important to understand for the partner of that woman. So if that woman, for instance, had a stroke or dies, it means that you're left alone with the baby. And that is something which really carefully people need to understand before they plan, for instance, the number of pregnancy or go ahead for contraindicated pregnancies. So what's a practical approach? So first we need to know, does the patient is known to have a heart disease? So is no, then you need to follow a diagnostic algorithm. I showed that just now. Yes, you managed underlying according to the condition the patient has. Very important to understand if there are comorbidities, aggravating factors. Then if the patient isn't heart failure, like our patient, you need to understand the weeks of gestation. If it's more than, if it's less than 60 weeks, it's a question you need to discuss if it's if the pregnancy is desired, if there is severe heart failure, really one should really in early pregnancy think about termination. It's a very high risk to continue. And if it's more than 60 weeks, let's say someone is 26 weeks, you usually try to stabilize the patient, think about early delivery and other specific aspects. There are actually dedicated papers from the ROPAC registry on the pregnant women with uncorrected congenital heart disease who really go into much detail about all those different scenarios of complex congenital heart disease, the risk for the women, the stroke risk. There's also a paper on pulmonary hypertension and pregnancy outcome. I can just tell you, if you have pulmonary arterial hypertension, the risk to die is 50%. So it's a high risk condition, and other options to have children like adoption should be really considered for those families. Then if your patient has rheumatic heart disease like our patient, you think about medical therapy. So it depends. I don't have time in 10 minutes to go into all the different options, but there is ways how you stabilize the patient with medical therapy. If for instance, atrial fibrillation, fast heart rate, if there is mitral balloon valvotomy, if the mitral valve is tight, If there is, if you have then other conditions like congenital heart disease, it's often too important to do more imaging to understand the complexity of the congenital heart disease better. And if it's to decide how to stabilize the patient. This sounds all very overwhelming, and it's really a complex area, but there is very detailed reference work. There is a paper which I don't show you now. It's from the ESC from 2018, the guidelines on heart disease and pregnancy altogether. It's 80 pages. It's free to download online, and you find really information on the specific conditions. There's also a more recent paper on risk stratification and management of women with cardiomyopathy, heart failure, who have heart failure, like our patient, planning a pregnancy or presenting during or after pregnancy. And that's a position statement of the Heart Failure Association of the European Society of Cardiology study group on PPCM, which also goes through not only the diagnostic pathway, but also the management. This is my last slide. So what is also important, so you have the WHO criteria, the risk stratification, but don't forget the more general factors. So there is, for instance, the maternal health factor, late presentation, more than 20 weeks, detrimental when they only come for the first assessment, 20 weeks. If they have pre-existing heart failure, atrial fibrillation, it's reported that they have clearly a worse prognosis. Anemia, important, contributes to heart failure. Important to understand if you have the health system factor, if you have unskilled healthcare workers, lack of tools to make an early diagnosis, inappropriate referral algorithms, so the patient comes very late to you. Long distance to appropriate care is clearly a predictor of poor outcome, or it's a factor to consider if you plan a pregnancy. Then you have the maternal socioeconomic factors, if the woman is very young or older, poor maternal education, low household income, and poor access to appropriate care. So just to end my presentation, so this woman who came to the Charité, that she had rheumatic heart disease, she had mild mitral stenosis and atrial fibrillation, so with some digoxin and a beta blocker, you can slow the heart rate, and then the patient is stable enough to return to South Africa and give birth here in my hospital. So in conclusion, each woman with substantial heart disease and pregnancy is unique. The effect on the mother and the fetus need to be balanced and discussed with the entire broader range of family and support care system like parents or friends. A multidisciplinary approach including the cardiologist, obstetrician, anesthetists, the cardiothoracic surgeons and others should be put together for a tertiary center and be consulted. And understanding the precursors of preventing heart failure pregnancy will have the highest impact. With that, I thank you.
Thank you. Thank you to you, Karen. There's been really a very clear, comprehensive, let's say, vision of what we really need to do for these women. Alex Mebaz, of course, cannot take, don't want to miss the opportunity to talk with you. Alex.
Thank you, Karen, for this great presentation. I mean, you're indeed one of the world experts. In the great network, we love biomarkers. And you didn't mention so much biomarkers. Can you give few clues for the people in the room who may have those patients coming? If you can give maybe 2 or 3 tweaks. For instance, there are many people saying, oh, during pregnancy, the biomarkers can go very high, etc. And you showed many times it's not true. Yeah, can you give us 1 or 2 tricks, please? And again, thank you for being with us.
Yes, it's a pleasure, Alex. So there is actually very good data of the usefulness of anti-proBNP or BNP. And there is a study which was presented by Dr. Charles Viljoen. He is part of our team here at the ESC Heart Failure meeting in Prague. So the paper is unfortunately not yet published. but he evaluated NT-proBNP as a screening tool exactly for the patient which I've described. And there are some older information which thought that NT-proBNP is not useful in pregnancy, but this is wrong. There is a slight increase of, let's say, 5% while you are pregnant. But I mean, if you have proper evaluated values, it's a clear indication that the patient has heart failure or left ventricular dysfunction. So it's a very useful screening tool if you, to find out if the patient has heart failure, needs to be referred to a center where they can do cardiac ultrasound and other tools to work up the patient. And obviously, I mean, the classical biomarkers which you use for other conditions like the troponins are working exactly the same in patients who have ischemic heart disease. And as I mentioned here, I'm not sure how it's in other parts of the world, but in Cape Town, unfortunately, due to the strong smoking history of many women, obesity, poor access to good nutritional options, we see really many women in the early mid-30s who have already diagnosed ischemic heart disease and are coming pregnant. So if they present with chest pain, you really have to respond quickly, use the same markers as you would do in a non-pregnant patient. The markers are working equally well.
If there are no other questions from the floor, thank you so much again, Karen. We hope that next year you will be with us in presence, okay? Have a good rest of the day.
I try to time my travel better next year. Thank you very much.
Ciao, ciao, Karen. Thank you.
Bye.
Now, I